Good morning. I'm very honored to be here this morning and share the stage with our three fabulous panelists who bring very different experience and different perspectives as it relates to physician leadership and requirements and solutions to enable leaders to drive organizational change. I'm also very happy that I can also call these three panelists my three colleagues. I feel very fortunate, and we are very excited to be here today to share with you our experience and share some lessons learned that hopefully you will be able to bring back to your organizations. Today we're going to discuss the impact of healthcare reform on leadership requirements and really just frame it for all of you because I think you're all very well aware of what's happening. And we're going to talk about tactical strategies and solutions as it relates to three different levels of physician leaders. Physicians leading physicians, physicians leading teams, and physicians leading systems. And before we get started, I would like to introduce you to our panelists. Sorry about that. Our first panelist is Tracy Duberman, and Tracy is the president and CEO of the Leadership Development Group, which is an executive assessment, leadership coaching, and group development firm. She brings with her a wealth of experience in the field of leadership development, partnering with clients to develop solutions for their leadership and organizational challenges. Tracy holds a PhD in health policy and management from New York University. Her doctoral dissertation was assessing the critical behavioral competencies of managed care physicians, and it was used as a guide for physician selection at one of the largest managed care organizations in the early 1990s. Tracy's a frequent speaker on topics such as emotional intelligence, strength-based leadership, and change management. She sits on the board of the Physician Coaching Institute, is a fellow of the American College of Healthcare Executives, and is a member of the American College of Physician Executives. To her right is Dr. Len Fromer. He is the Executive Medical Director of the Group Practice Forum, which is a physician-led organization designed to provide group practices with information and solutions to maximize efficiency and effectiveness. Len leads a team engaged in national projects with group practices that deliver education, tools, and services to achieve success in their clinical integration efforts. He's a member of the board of TransferMed and also acts as a consultant for TransferMed in the area of clinical integration, focusing on chronic disease quality improvement and successful practice transformation toward patient-centered medical home and accountable care. He's also a fellow of the American Academy of Family Physicians, a diplomat for both the American Board of Family Practice and the National Board of Medical Examiners. Dr. Fromer lectures extensively on a number of topics of health system reform, the patient-centered medical home, and the accountable care organization. He's also an assistant clinical professor for the Department of Medicine at the University of California. Scott Connard, Dr. Scott Connard, to the right of Dr. Fromer, is the Chief Medical Officer of ACAP, which stands for Accountable Care, Accountable Patients Health. It's ACAP Health. And ACAP Health focuses on asset management for employers. And really what they do is they empower employers to manage their employees' health equity investment to best address their employees' healthcare needs and get the greatest return for their investment. Scott possesses over 2 decades of experience as medical director, business executive, physician leader, and medical researcher. He is driven by a strong commitment to the transformation of healthcare into a patient-oriented, physician-directed, accountable system with aligned incentives to ensure that all stakeholders win. And Dr. Connard is also a member of the Group Practice Forum's advisory board. And I just realized, there he is. And I work, as I mentioned, with everybody here. I work for the Group Practice Forum and have partnered with all of the panelists to bring solutions and leadership development programs to all of you. So without further ado, let's get started. We're going to just I'll quickly frame, the landscape, which I know you're all well aware of. And then Tracy's going to come up and share some challenges and opportunities for physician leaders, as well as a roadmap to high-performing physician leadership based on research. And then all three of our panelists are going to walk through some vignettes based on those 3 levels of physician leadership I described earlier, and share with you their experience and solutions that have worked. And then lastly, we're going to leave some time for questions and answers. So I think everyone here is aware that the train has left the station. While we're still waiting to hear what's going to happen, what the Supreme Court is going to decide, one thing is for sure, the paradigm shift is occurring, and there are lots of ramifications for going from from volume-based healthcare delivery to value-based healthcare delivery. And it's going to take very strong leadership to lead this change. And there are a number of drivers, obviously, driving this paradigm shift. And I think everybody in this room is well aware of all of those drivers. And the exciting part is it's really leading, or it's creating an opportunity for all of you as leaders to drive this change and help make it happen the way we want it to. So without further ado, I'm going to turn it over to Tracy Duberman, who is going to share with you a roadmap for high-performing physician leaders.
Thank you, Lisa. Can everybody hear me okay? Yes, good morning. For those East Coasters, you've been up for quite some time. For you West Coasters, you're probably exhausted. Thank you so much for joining us this morning. We really appreciate it. As Lisa said, my organization focuses on leadership development, mostly with Fortune 100 companies working with corporate executives. We do a bit of work now with physician leaders, and we decided about 5 years ago that we wanted to spend some time researching what the critical success factors are for physician leaders today. As Lisa mentioned to you, back in the 90s, I'm embarrassed to say, you probably all know my age at this point, I did some research for my PhD looking at pivotal competencies for managed care physicians. Well, the world has changed significantly, so we decided that now we wanted to take a look at what physician leaders need today, behaviorally, from a leadership perspective, in order to be successful for accountable care. So we partnered with the Group Practice Forum and my wonderful colleagues here to my right, and we conducted a research study to do just that. Actually, all of you, or many of you, and some of your colleagues participated in a survey that we did last year. We put a very simple question out to the American College of Physician Executives, and that question was, what keeps you up at night? And we got about 100 or so responses, and we collated the data, and we came up with these 5 major themes. And I am imagining that these themes are going to resonate for all of you. The opportunities and the challenges were around these items: how to identify and communicate metrics to define physician value to patients and health partners, understanding clinical systems thinking and applying the concepts to new models of care delivery, communicating effectively to engage patients and other healthcare providers to work as a high-performance team, a lot of the work that Scott Connard does with his group. Implementing patient-centered clinical integration, and Dr. Len Firmer will talk a bit about this, and leading culture change rooted in trust between physicians and the health systems, health plans, group practices that they support. So we thought to ourselves, given these incredible challenges, what are the leadership skills that are required of all of you in order to engage in these changes and make these challenges become opportunities for success? So as I mentioned before, we partnered with Group Practice Forum, and we did a research study with a number of physician leaders from large group practices around the country, such organizations as Dean Health System, Health Partners, Holston Medical Group, the Iowa Clinic. Both Dr. Fromer and Dr. Kennard were study participants as well. And we did something that we do in organizational development consulting. We did a competency modeling study where we did behavioral event interviews to identify what the critical challenges are and the reactions of high-performing physician leaders. We also did some psychometric testing to look at what the intrinsic motivations are of high-performing physician leaders. And we codified the data, and we came up with our physician leadership model. In your folders on your table, in the black folders, we have a white paper detailing the study and the results. If you don't have enough folders on your table, if you leave me a card, I'll be happy to email you the study so that you can read it at your leisure. I'm just going to review the results with you very quickly right now. When we coded the data, we saw themes arise, and those themes we put into 4 pillars around leadership. The first pillar was around leading self. This is really around emotional intelligence, the ability of physician leaders to be self-aware, to manage their emotions, and to be involved in self-development, what we call learning agility. The second pillar was around leading others, building effective teams, and doing so through communication and inspirational visioning. The third pillar was around leading for change. And this really is around courage and resiliency, being authentic and understanding the concepts of change management. And the fourth pillar around leading for results. And these were competencies such as business acumen, much of what you learn here through the ACPE, being decisive and understanding systems thinking, how things come together in terms of the parts becoming a whole. Again, the model is detailed in the white paper in your folders. The model is great, and it's a wonderful roadmap in terms of successful performance. But what we really wanted to understand was, how do we help physicians in developing these competencies? And so we took a look at the research, and best practice in terms of adult learning methodology that corporate America has been using for decades is something called the 70-20-10 rule. And what that means is that when you're trying to develop a new set of skills or behaviors, one ought to be focusing 70% of the time in terms of on-the-job training, 20% through coaching and mentoring, and 10% through didactic training modules, which for many of you may seem like it's throwing the training that you've gone through sort of on its head. So we developed an approach to leadership development that really incorporates a lot of on-the-job training. And for those of you that were here for the annual meeting that attended the Little Bets seminar, a lot of what we do is around action learning, utilizing a methodology like a Little Bets. So with that being said, where we really want to focus the rest of our time this morning with you is to go through some real practical vignettes about how physicians are developing these leadership skill sets. We're going to have Len Fromer talk first, a vignette around physicians leading physicians, and then Scott will talk around physicians leading teams. Oh, I have that reversed. Dr. Conrad is going to talk about physicians leading physicians, Dr. Fromer around physicians leading teams, and then I'll come back on and talk a little bit about physicians leading health systems. So thank you very much. Dr. Conrad?
Yeah, perfect. Thanks. All right. Well, I can imagine you'll find yourself in a similar position to what I'm about to describe at some point as you go through your physician leadership training and development. I'm a family physician. I've been in practice for 24 years, and I had built a patient-centered medical home, although we didn't have that term back in the early 2000s. I had a paperless system. We had 3 locations, 12 physicians. We had a lifestyle program with bariatrics as well as a sleep lab, DME companies, that kind of stuff. And I was the leader and had developed all that. So in 2006, my practice was acquired, and I became the chief medical and strategy officer for a group of 343 physicians. We had about 1,070,000, that was primary care, and then 70 specialists. And we had full ancillary, we had our own lab, et cetera, et cetera. So the reason they had brought me in was to go from the volume-based care to value-based care. And my job was to help take these physicians, which were very independent in the way that they operated, and bring them together and move them into value-based care from the volume. So in going in and really trying to figure that out, it really became clear to me, I'm going to kind of summarize 5 years of life experience and try to make it as simple as possible. Because the thing that became clear to me is that to try to get the physicians to start to do things different was naive, and it was a Sisyphus maneuver. You know, it's never going to work. So what actually we came to was we got the physicians together. We asked them, what is your vision for what you think value-based care is? And there was all over the waterfront, right? Everybody had a different opinion. So we kind of had our opinion as the leadership also. So what we did was, and by the way, let's go. That's good. So we looked at all the assets that they had in place. We got their opinions, and we built a infrastructure to have them start to see themselves in a different light. And it was really through this infrastructure that we identified who was going to engage, who was going to really be our leaders, and move the whole corporation forward. And I'll show you what that looks like. So again, 50% of them were, at the beginning, it was 16% of them were on electronic medical records. So this is a very primitive group. And actually, I'm speaking about the more primitive. Len's going to come up and speak about a much more sophisticated group if that's where you find yourself today. But this was what we see right now, like with all these hospitals going out and acquiring practices or physician groups trying to come together, and it's all over the waterfront. That's what we had. By the time 4 years later, we had over 50% were on medical records, and about 85% were scheduled to go on. So that's all being rolled out right now. But they were very much a physician-centric. You come in, you get your 10 to 15-minute block, and you're just trying to stay on time, and you're moving people through. No real significant population management among the group. And it was a very strong fee-for-service. This is in Dallas, Texas. We actually had groups in Raleigh-Durham, North Carolina, Dallas, Texas, and in Las Vegas, of all places. So the first thing that we really learned was that we had to give, you're going to teach somebody to fish rather than give them a fish. So we had to teach them to start thinking differently. And I wanted to show you this. This is actually an example of the dashboard that we ended up developing. And what we did is every night we took all the lab data, we took all the ICD-9 CPT code data, and we matched them up by physician and patient, and we built a clinical data repository. And then we put in just the very simple criteria that you see here for BTE. This is cardiac care. And we created this dashboard. Now, the uptake of the dashboard obviously was different for different physicians. But what we found was that if you look over here to the left, these are months on the bars. And so we got the physicians together. We'd already asked them, what is your vision for leadership? And getting BTE NCQA recognized was one of the things that they all wanted to do, or the majority of them wanted to do. So we said, okay, here we go. Here's your score. And when we turned on the dashboards and everybody got to see their score, what do you think their response was from that? That's not me. That's right. That couldn't be me. There's absolutely no way. I am a much better physician than that. And that was the story with 85% of them. One of the things that was really unusual is that we had 5 or 6 people that actually we turned on the dashboards and they were already 75 or 80 without the tools. And guess what? Those are people nobody ever would have paid attention to. They were quiet. They were introverted. They loved what they did. They never showed up at meetings. They just really did what they did. And it was so interesting to take those people and highlight them as true leaders of our groups. And all the people who do this all the time and were coming to all the meetings and had an opinion about everything, they were down in the 20 range. So here these quiet introvert types actually get their moment in the sun, and we started to see them open up like flowers and really become much more willing to lead once we could show their benefit to the group. So anyway, this is an example of a physician. This is actual data. This is one of our docs. And what you see is in the first 3 months, this was turned on, and he's like, oh, that's not me. Can't be me, da-da-da. Well, here's the key right here, right? This little button that says patient details. And when you click on that, guess what comes up? It a list of all the patients and all the criteria, and it's coded red if it's not a goal, yellow if it's close but not quite there, and green if it's a goal. And so the doctor would go in, they'd hit that, their patient list would come up, and next thing you knew, they were going, well, I know Betty. Oh, my, you're kidding. I haven't gotten her LDL in a year, and I just thought I saw her did it. Oh, yeah, that was a sinus infection. I got to call Betty back in here. Let's get that done, would you? And pretty soon it empowered them to start to work on it. So they thought, I'm going to change the way I behave, and this will get better. But you can see the first 4 months didn't make a whole lot of difference. But some things started to change, and the doctor, as the cowboy, was able to get his score up to, in this example, 30, and but still didn't get better. So finally, after 6 months of frustration, he was like, where's the office manager come in here, or head nurse come in here? I need you to take over and make this happen, right? And look what happens. So as soon as he turned it over, he quit trying to run things, he quit trying to manage things, and he just said, this is important to me. Things started to change quickly because he did what he did, or she did what she did, and let the staff start to be more than blood pressure checkers and telephone operators. And they became enthused. We actually had a turnover rate in some offices of up to 70% at a 12-month period, because if somebody offered them 25% more and it was closer to home, they'd take the job, right? Well, as soon as we had them start to become healthcare professionals instead of blood pressure checkers and phone answerers, we literally had our turnover rate at the offices that started to work on this drop down below 20%. So it was a great experience. But the other thing that happened is we saw who the real leaders in the group were. And as the chief medical and strategy officer, what I did then was I looked at who had really stepped up and was excited about this and had communication skills, and named a North, East, and West regional medical director. And we took each region and divided it up. Now remember, there's about 100 primary care physicians, 112 primary care physicians in each one of these regions. And then we broke it down into 30 under each area medical director. So they'd have about 30 primary care docs and 8 to 12 specialists. And basically, they just got to share the progress of all the physicians in their group. So very simple, not anything that you'd really expect from some Harvard MBA program, but something that was very, very effective. And to show you from the day we turned on these dashboards in August of 2008, and then what we achieved is in diabetes care, cardiac care, and what you see is at level 1, 2, and 3 through the year in January 1st of 2010. So let's see, I'll make sure I got my time straight. Yeah. January 1st of 2010, we had 15 people that had recognitions. By January 31st of the same year, we had 149 that had achieved recognition. And if you took the actual work that was done in that year, which you'd have to go out to April and see who got recognitions, we had 163. So this was an example of us transforming our culture from volume to value, really through, number one, having a shared vision among the physicians, number two, giving them a tool, and number three, really looking at who stepped up and engaged, and then having our physician leadership come from the change in behavior and identifying the leaders within our group, as opposed to me going out and saying, well, you sure do speak well and you sure do seem interested in this and so forth, and trying to do it from my opinion. We actually worked from within, and it worked extremely well. So that said, that's a very primitive example in the sense of we started from basically nothing and created a system of care that was able to be very successful. By the way, the last fact I'll mention as Len comes up here is that we, Blue Cross Blue Shield, was tracking our cost per patient and so forth and so on. And as you can imagine, after 1 year of this effort, it really wasn't a very sophisticated patient-centered medical home in the majority of offices. We were starting to do things a different way. Things were going along relatively well, but there still was a lot of work to be done. And when we tracked it, we were saving for every patient seen at that office, whether they had cardiac disease, diabetes, or not, about $38 per person per month. We were that less expensive than the other physicians who had not gotten the BTE recognition. So while it was primitive, it was still early in the process of the genesis to a patient-centered medical home. When you take the number of patients we were seeing, that $38 was a huge, huge amount of money. And the physicians got bonused on that, and in the first year, there was about $380,000 of additional compensation that was given back to the physician. So it was on its way to success. Len?
Thank you, Scott. Good morning, everyone. It's good to see faces and folks from haven't seen since San Antonio, I think, last year, and rekindle this topic. The vignette I want to cover is about leading teams, and I particularly like what Tracy said when she talked about the 4 pillars of what we learned in the research project. The one that was focused on, for me, was leading others and teams and the visioning and coaching. And what struck me was, as we go through the vignette, there's a wonderful analogy here between clinical excellence in delivering care to patients and the gap that we need to address every single day. The struggle about taking the knowledge we all have about what we should do, knowing the guidelines, getting the question right on the exam. But then when we put our teams in front of patients, the right thing doesn't happen. And that gap is clinical integration. A little different than the other clinical integration that has been championed by Advocate Healthcare and some other big organizations around the country. Our clinical integration, what we do at Group Practice Forum, is addressing that knowledge-action gap. The analogy to leadership is that there's a gap between what we all know and understand and have learned about how to lead and about the ability to put that into practice and say, how do we make this happen, particularly around leading teams in the change from volume to value. This vignette is a real story about a group that was doing quite well and in their region was one of the leaders in terms of getting great outcomes metrics, great patient experience scores, doing very well in a health plan that was their dominant health plan in their region that they had started with other doctors, owned by physicians, started by physicians, designed completely to be patient-centric on generation 3 of patient-centered medical home. But they wanted to be best in class. And they recognized that they had a problem with too much I going on all day long versus us. And getting the team collaborative care approach embedded in their workflow was what they felt was the problem. They weren't efficient at it, they weren't good at it, and too many people working in the practices that were in their network were not practicing reality, day-to-day, team-based. So they picked up the phone, called us and said, come on in and help us do this, launch a project that we can do to really get towards this whole idea of how do we vision, how do we coach, how do we spread the word into every member of the team, to lead themselves, and get out of this I, and get to the we. So what we designed was an approach to address this gap. And what you're going to see is the challenge that's up there, the challenges that are up there, being addressed by something Scott actually brought up, which is the whole idea of having the concept of if you have the tools and you have the knowledge, you have a way to put together an actual workflow that leads to the outcome you want. And in our case, what we do very frequently and did with this project was create a journey of care through a disease process as an example. When we did the needs assessment with this group, we said to them, pick a disease for us that you struggle with more than any, a chronic illness. And they picked COPD. There are several reasons why they picked that, one of them being that the health plan was focused on that particular disease state and improving readmission rate metrics and patient engagement and so forth. So we picked COPD and we said, okay, let's build a process map, timeline left to right. I know you can't read it, I just put it up there as an example, of a process with tools embedded in that process that we will build, that your teams will build to engage every member of the team and pretty much make it fail-safe that every day going through the workflow with that particular disease, they would have to function as a team. They would have to play off each other's strengths and weaknesses, fill in the gaps, and what kinds of things came up. Well, what you see is the team actually, after the needs assessment, sits down and I was very interested when I arrived here yesterday, turned on the Twitter account, and you had someone here, Andre Delbecq was here in the, at the meeting, and Andre actually is somebody we quote in teaching this because he's the one who came up with the concept a number of years ago of tweaking brainstorming as a decision-making process to a nominal group voting, which is a really empowered way to take a group of people who are going to be on a team and have every single person learn to contribute, engage, and activate in getting this done if they're going to build this workflow. So we had them sit down, we had them go through nominal group voting, we had every member of the staff engaged and involved on the teams to build this COPD workflow. We gave them tools to help that happen. So how do you lead to getting teams and clinical integration? Well, one of the tools is a task grid. Checklist tools, simple tools, on paper or electronic, it doesn't matter. But consider the concept of saying, if we're going to take a disease state and we're going to look at what has to get done to get great clinical outcomes and great patient experience scores, then what are the tasks that need to happen? That goes across the top. Down the left, who's on the team? And who's on the team, in their case, very important, is not just everybody physically in the site where the care is happening. It's beyond the four walls of the practice. It's reaching out into the community. It's network resources, health plan resources, who's on the team, most importantly, including the patient, and how do we then start to fill in the boxes of who's doing what. The task grid, the checklist process, multiple tools to get that done, ends up building across the pillars of what you see at the bottom of impacting care, team coordination, empowering the patient, raising health literacy so patient engagement works, patient population and disease state management, and using HIT to do it. How do you build, based on those pillars, from each team member's input, what that process map looks like? And what's in the color-coded pieces across that timeline is this strategic model to assess, diagnose early and accurate, and then implement a regular planned care model looking forward that the team's going to do, not a rescue the sick model, right? We take that, we always do that well. We're built around that in a volume-based system. We spend our days and nights putting out fires. But we have to figure out a way to get past that to the important non-urgent work, and that's what this is about. Team members who build it. So in those pieces of literature or content underneath each of those color-coded circles and boxes are the actual elements around in these journeys what the team members do with the tools. Engagement with the patient between live visits, outreach to the patient. Who's doing that? Who's going to call the patient after every chronic care visit and say, did you understand what happened yesterday? Do you have any questions? How are we going to help you adhere better to the medication, to the lifestyle change? A 1-minute script, never one that is done by the person in the white coat, the physicians, but team members who are in the task grid to take care of that. And they engage, the team members start to think we and not I, and they go through those pillars and enact and implement this. What happens 100% of the time is when they start to do this on a particular disease state, it takes about 1.5 minutes for somebody on one of the teams to say, wait a minute, we could do these same things with diabetes. We could do this with cardiometabolic risk. We can do this with asthma, and on and on and on. They learn that it's really extractable to almost every single chronic care condition. And the basic principle gets right along the 4 pillars that Tracy talked about, gets right into the things that keep us all up at night. How do we get all of that done across the need to move to value? And really, it's about looking forward and not looking backwards. How do we lead into the teams to get this done? So it's tools to make it happen. Really goes along with what Scott did, really the same kind of thing, but not on a physician-to-physician level only. It's about helping the team lead through the care process change into the chronic care model. So I'm going to turn it over to Tracy, who's going to take us through leading to systems, and we'll pull it all back together during the endpoints and discussion. Thank you.
Thanks, Dr. Fromer. So the last vignette, but before I get into the last vignette, I think what's very interesting about what Dr. Conard and Dr. Fromer talked about was that it takes a really concentrated effort to make any type of change and to develop any type of leadership skill set. Concentrated efforts from the perspective of having the right tools and techniques in place, and then having the right people there to really engage folks in the change from a visioning perspective, and also in terms of utilizing the tools and techniques that we have available to us. So my vignette is around a health system that we're currently working with in the Northeast. It's a nonprofit multi-hospital system. Right now 3 hospitals, and they're looking to acquire another 2 by the 3rd quarter of this year. They currently have around 3,000 affiliated physicians. Only 10% are employed by the health system, which is very common in the Northeast. They also are a CMS shared saving ACO, actually the largest in New Jersey. The challenge for them was around having alignment from the voluntary and the employed physician staff. The reason why was to enable clinical integration so that they could be successful as an ACO. And they had a focus really on growth and innovation. In the Northeast, at this point, it's really about who has the most hospitals in their system. And especially in terms of primary care feeding the systems. So that's really has been their strategy. So they came to us and said that we wanted to develop an on-site physician leadership program. And we wanted to start initially with our full-time employed chairs and department heads. And we wanted to use an approach that incorporated what I talked about earlier, utilizing in-classroom didactic training coupled with action learning projects, coupled with coaching and mentoring. So what they did is they used us to work on the Applied Physician Leadership Academy, which is a joint academy developed by the leadership group in conjunction with the Group Practice Forum. And what we did is we took each one of the physician executives through an individual assessment to identify where their leadership gaps are in terms of the leadership behavioral model that we put together. And we also did an organizational priority assessment to understand what the key challenges are for the organization. And based upon those challenges, we developed some action learning projects for the group of physicians to work on. These are huge projects that they're working on. One of them is around how to improve quality while reducing utilization. Another one is around improving patient outcomes. These are big ticket items, and they have the full year to work on these projects and come up with solutions that will then be prepared for the steering committee, which are the senior leaders of the system that we're working with. And the senior leaders have committed to implementing the solutions that the physicians are developing. So there's a lot of stake in the game. We are also doing in-classroom didactic training. We have many folks from the ACPE and others around the country coming in and doing specific talks on particular gap areas for the organization, one of which is around creating high-performance clinical care teams. We're doing another module on business fundamentals for physician executives. It's been a really encouraging program. And then lastly, we do a lot of networking because physicians, unfortunately, don't have a lot of opportunity in these health systems to get to know each other on an informal basis. And as we all know, having those relationships is incredibly important in terms of change. So this is an ongoing program. We started in January of this year. It'll end in December. We're having a big gala for the folks that are going through the program. They're getting continuing medical education credit for it, so a lot of people are involved in that. And it's been great so far in helping to engage them in change. So now I'm going to turn the mic over to Lisa to summarize what we've talked about today and leave some time for Q&A. Lisa.
Great. Thanks, Tracy.
Right on time.
So just to summarize kind of the key takeaways from today, I mean, obviously, we all know we are in a different world in healthcare, and it's time to really make a change, and change is required. We shared with you 3 different vignettes that hopefully, at least some, if not all of them, resonated with you, and you can take them back to your practice. Thinking of it even from small baby steps in a primitive practice, what are some tools that you can use to really start to get physicians to lead, as well as get teams to work together, and then at more of a macro level, how do you start to get the whole organization to start moving together toward the change that you want to see? And it's also clear that one size does not fit all, that leaders need to really understand where their organization is and align the tools and everything else to that, and start taking baby steps going forward. I'll now open it up to all of you for questions and answers. You can ask our panel some questions. And just to let you know, I neglected to say this earlier, the presentation is not in your booklet, which I think you all probably figured out by now, but we will be posting it online, so you will have access to it. And as Tracy mentioned before, they're also in the folders, but some of you may not have been able to get a folder. And if you want us to mail the white paper, any additional information on the research, we'll be happy to take your cards and send you that. So to kick off the question and answer session, I thought that I would actually start with some questions that I have for the panelists, and then open it up to all of you. My first question is for Dr. Connard, and I'm wondering, you talked about measuring physician performance and how that impacted your medical group, and I'm wondering how you handle resistance to that to that measurement. And actually, one other thing that I just remembered, you probably noticed that we have a video camera here, and we realized that in order for everyone in the panel to be filmed, I'm going to ask our panelists actually to come forward and stand here, which I know it may be a little awkward, but we are dealing with the placement of the camera.
Yeah, so to answer your question while we walk up here, really very much for us, it was don't kill the messenger was what we asked them to do. You know, actually, if you hit B on that, it'll black out this so we aren't standing in front of a...
Hit B?
Just hit the letter B. There you go.
Cool.
So anyway, so very much we saw it as us getting out of the way and empowering the physicians. And so, as I said, where they could click through and see their patients. At first, that's not me. I'm not that. I'm better than that. And then it was like, okay, cool. Well, let's look at that together. And it was the big mouth frog joke, right? Where, what do you feed your baby? And goes up to the alligator and says, I feed my baby big mouth frogs. And the big mouth frog says, oh, thank you very much, right? And you find that a lot with physicians coming out of the bag. But once we gave them and empowered them with the tools, and they got comfortable with it, and they got over the shame, if you will, of not doing as well as they thought they were, and then they empowered their staff, and things started to change, it gained tremendous momentum. And so we really saw ourselves as physician advocates. We were a physician-owned and managed group also. So we really saw ourselves as being there for the physicians. It's going to be harder for hospital groups and for third parties that are managing physicians to do that, I imagine, in some ways. But I would really strongly encourage have it be all about the data, not about the person.
Great, thank you. And Dr. Fromer, you presented, this wonderful patient journey for a team to align around patient care and patient-centered care. What are some steps that groups can take to just get started? Because obviously the journey is a big undertaking.
Great question. Where do I start is probably the very
Exactly.
most common question we get when people engage, teams engage. I think the first step is to recognize that they're already doing the heavy lifting. And you really get engagement and interest when you start to put pieces together that make it a fail-safe, easy lifting, not heavy lifting, to get to an end point that they've identified they want to get to. So we're talking about chronic disease, we're talking about look forward, we're talking about metrics that they're all aware of, they've been working in now for years. In the vignette you saw, they're on generation 3. They started that probably 7 years ago, patient-centered chronic disease, look forward care. They know what their targets are. Their struggle is process improvement, how to get there. So step 1, just start to do nominal group voting instead of brainstorming. Develop an easier way to have huddles and have team meetings and have the team get input from everybody. That same group, there's a terrific story about that same group having a problem with phone communication access for years. And they kept trying to fix it by the physicians at the top figuring out what the solution was, and it never worked. And a couple of years into the effort, and $500,000 worth of trying to fix it with new computers and phone systems and reorganizing how they did everything and hiring more operators, one of the operators came up to the lead physician in the group, the managing director, and said, "We think we figured out the answer." This was before they went to the nominal group voting. And what was happening was, in all the brainstorming sessions, the staff would sit and just nod, and all the input was coming from the managers and the higher level, the physician leaders. And that particular input from the operators solved the problem with no additional cost, actually saved them money and became more efficient in what the real problem was, which was the physicians, of course, and how they were giving instructions to the operators about how to schedule appointments. Everybody had given them a little pamphlet, for my appointments, do it this way. And it took them 15 minutes every time a patient called and said, "I want to see Dr. Smith, and I have to come in for a pap smear." And it was 15 minutes later that they finally got it scheduled by flipping through, what day of the week is it, and what hours does Dr. Smith work, and is the moon full, and then we do it this way versus if the moon isn't full. They threw out all the instructions based on what the operator's input was, took a radical step to go to long and short appointments. Again, things we know about what we should be doing, but struggle to implement in the real life setting. So it's really steps like that. Get the team engaged, nominal group voting first step, take a task grid, take a disease state, do one, lay it out, who's doing what in the checklist process, really starts them down the path on how to build that we versus I concept.
Great, thank you. And then Tracy, you talked about the Academy for Physician, the Applied Physician Leadership Academy. If you could maybe talk about how you customize that program
Sure.
for the different systems that you have.
Absolutely. And the word applied is very important.
Yes.
Because it is applied to the system that we're working within, and we try to customize it as much as possible based upon what we call an organizational priority assessment. So we'll actually survey the physicians that are working within the system to ask them what are some of the priorities and challenges that they're facing in the system. And we'll also ask the senior leaders of the system as well. For this particular vignette that I talked about earlier, we then took all that data and we consolidated it, and we identified about 8 different action learning projects based upon the priorities. And each of the physicians that went through the program got to choose the top 3 that they'd want to work on. And ultimately, they were assigned to one of their top 3 priorities. And that's the program, that's the action learning project that they're working on. So that's one piece of customization. The second piece of customization is looking at what the composite gap areas are for the leadership in terms of the behaviors that they require learning. And then we develop the didactic learning modules around those leadership skill sets. And we also do individual one-on-one coaching with the physician executives, working on their individual leadership strengths and development opportunities. So it's customized in a lot of different areas and respects.
Excellent, thank you. And now I'd like to open it up to all of you. Please raise your hand if you have a question. And yeah.
Hi, Peter Angood. We seem to have some conflicting levels of maturity out there in terms of creating change. One is measurement is pivotal. We need to know what to measure, how to measure, how best to do it, and yet our measures aren't that sophisticated. The second piece, and the NQF has nearly 700 methods out there. They're working to refine them. The second piece is that we as physicians always want the data. We're looking for ways to resist change. What's the first thing? Show me the data. So my question is, so we've got inadequate measurements, we want the data, but we're still trying to create change. So how do we create change while we're creating the data in perfect measures?
Dr.
I was going to.
Yeah, no, I mean, I'll dive in, or you can dive in, or whatever. But we do it all day long. The answer to your question is so much of what has been surprising to me about really stepping up and trying to lead a large group of physicians. We started again with 343, ended up with 510. Was it's the same way that you manage a patient with, once if all you have is a hemoglobin A1C, but you really don't know how many hours they sleep, how much they're eating, what the grams of carbohydrate is, how many minutes of exercise they're getting, and all the other data that would surely be wonderful to help us be able to manage that patient effectively. It's about communicating, getting in their value system, figuring out what's important to them, and finding that teachable variable, if you will, that they're willing to latch on to, that you can get to. It takes time, energy, and effort. It really does take a lot of, in a sense, as a chief medical officer, one of the things I've learned is it's very much about me understanding what's important to them, just like as a physician, it's me understanding what motivates my patient. And I think that my tendency starting out in my job was I thought I had to have the tool to make progress. What I learned very quickly was once I understood the physician I was working with and what motivates him or her, I could get them moving very quickly, and this became the icing on the cake. So it's really about that physician that you're leading. It's about what motivates them and what they find important. And my experience is that the thing that most physicians are most afraid of is making the big mistake, right? It's doing the thing that actually causes a problem or causes the thing that they've gotten comfortable with to change in a negative fashion for them. So in looking at, we call that the competing commitment, right? So they say they want to do this, but they're doing this. There's a competing commitment that has them not be willing to move. So what is it that's holding them back? And if we can understand that and understand what's important to them, then it's almost like cutting the rubber band off and that's holding them back and inspiring them, and they start to move. So focusing on what's important to them and figuring out what the competing commitment is that kept them from getting off the dime, what their fear was that had them be afraid of what mistake that they were afraid of making. Those two things together really, it was amazing how it took time for each one, and each person kind of lit up at a different rate. But once you got a person there, you almost had to get out of their way because they would move forward. And they'd find a way to get the data they need if it was that important to them.
I hear in what you asked a lot of the real underlying issue being the chicken and egg conundrum. What's first? Do we react to a change in the external environment that's now leading us to make change, or do we make that change happen? I think it happens over and over again in everything in healthcare. The pieces that have to align to deliver value-based care revolve around quality and cost. Well, if you're in an environment where you're doing a terrific job in delivering value, but you're in contracts that only pay for delivering volume, how do you lead people into that chicken and egg change? Which comes first? And I think leadership really boils down a lot to saying we're going to be proactive and not reactive. We're going to say we're going to make that external change happen in something like the payment model around us. We're going to do what Advocate did. Here's our value proposition. Tell Chicagoland, where they have all of their catchment area, tell Chicagoland, we do it better than everybody else. We measured it, we prove it, here it is. Take that to the payers and say, therefore, we should get more for what we do because we deliver this. Not wait and react, cause it to happen. I think that's the same with quality metrics. I mean, do you want to wait around until the metrics are defined in finality? They're never going to be defined in finality. It's changing all the time. But take the basic buckets that we know are the important quality outcome metric scores, process improvement, disease outcome improvement, patient experience, and say, here's what we think matters for this disease state, this group of patients, and make that change happen. I think that's frequently what leadership is.
And so to some degree, it's actually parallel processing while you're creating the
That's right.
generating
Right.
data.
Yes.
Immaculate conceptual data.
That's
Right.
very true.
Yeah. Yeah, I was just going to say, I mean, I think at the core of your question is really about what do you do about resistance to change? Because, you know, people will always point to what's wrong with either the data or the rationale for the change, whether it's data-driven or not. And so I think, you know, really good leaders are people that can identify what's going to motivate each one of the individuals that they're trying to lead through the change, and then drawing upon that. Because not everybody is motivated by the same thing. Data will motivate some, but not all.
Yeah, I guess what I heard you say is that in the world that Peter portrayed, which is there is no perfect data or perfect information, there's no perfect, unambiguous external reason to do it in a better way. That both Scott and Len said that underneath all that, it's really interaction that drives change, not data.
Right.
And the Nobel Prize in Economics said this several years ago, right? In the face of all this data, people still make emotional economic decisions.
That's right.
And then as Len said, you're moving from reactivity to intentionality.
Mm-hmm.
If you combine intentionality and interaction at the very fundamental interpersonal level, things start to roll.
Yeah, I would strongly recommend. There's a book out there called The Power of TED. TED stands for the Empowerment Dynamic.
Yeah.
It's a very short, 98-page book. And I would virtually guarantee you, if you can get your physicians to read this 98-page, it's a proverb or a parable. You'll see that intentionality start to just emerge without them really understanding what's happening. But, you know, the Cartman triangle, where the deadly drama triangle versus the empowerment dynamic, making that switch is what you just pointed to very well. And that is a very easy 98-page book. You can have the office managers read it, the physicians, everybody in the office can engage in that. It's a wonderful tool to go from reactive to proactive, what holds them back to what their vision is. And that truly is the paradigm shift that within a group we have to make as leaders.
Great. We may have time for just one more quick question, if anybody has another question.
But not seeing a hand. One quick comment that I want to make is you talk about going from volume to value. In our group, when you start to practice a more comprehensive approach, the revenue per visit went from about $97 up to $124 per visit. So for the average primary care physician, every visit was worth 20%, 25% more to that doctor. And from a systems level, we brought it down $38. So the doctor's making $20 more, and the system is saving $38. And so many people said you can't practice, it's not about volume, no one's paying for it, blah, 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 blah. That is garbage. And I would strongly challenge anybody who tries to take that argument on. The first doctors who engaged in this, their income literally going home went up by 20% to 25% because it all fell straight to the bottom line because their fixed costs were covered. Now, there's some variable costs with the immunizations and things, but the net bottom line was huge to the primary care doctors. So in today's system, it actually pays very well to practice high-value medicine. And I would take that one on head on because, and if you track the data, which is billing and collecting, which is easier to track because we all have to do that, you'll see a huge change. And so for those doctors that are motivated by financial success, it shut them up pretty quickly when their peers started to practice high-quality medicine. We tracked it and could show them how that was also higher value to the system and generated more for the primary care doctor.
Yeah, Scott and I have talked about this a lot, and that's a great strategy for responding to the pushback you get frequently from systems change, which is how do we deal with the transition time in going from volume to value. Volume doesn't disappear, probably never will disappear. Great strategy to deal with that and engage people and really give them a success story for right now, not for 5 years from now.
It's all about baby steps. Taking that next little step that gets you a step closer to the vision that you have for your group.
All right, and I think we're out of time. So thank you so much for your time.
Thank
and
you.
again, And again, the presentation will be available online. So thank you.
One more.
Thank you, Lisa.